Story 1. Ward 13 Transfer. At 3:18 in the morning, the psychiatric intake board refreshed and placed my employee number in the admission queue. Not beside a staffing assignment, not under transport or consult coverage. It was listed where patient identifiers went under an active involuntary hold, current location pending transfer to Ward 13. My badge was still clipped to my scrub top. My pulse was visible in my wrist. I was standing at the desk when the system placed me inside itself. Then, somewhere beyond a fire door that should have opened onto a dead corridor, a call bell began ringing in a slow, even pattern, like someone who knew I would come if they kept asking politely. I had worked nights in psychiatric intake at St. Gabriel Behavioral Health for 7 years. It was a private hospital in Los Angeles attached by enclosed bridge to a university medical center. And people who had never done the job usually misunderstood what psychiatric nursing involved. They pictured emergencies, violence, dramatic restraints, and strange confessions. Most of the work was quieter than that. It was repetition, procedure, phrasing, observation. It was knowing how to speak to a frightened patient without making them feel cornered. It was counting sharps, reconciling medications, documenting belongings, verifying legal hold language, checking that every wristband matched every chart and every chart matched an actual breathing person. Late autumn always made the unit harder to manage. Families were strained, sleep schedules collapsed, students came apart near midterms. Patients who could hold themselves together through summer and early fall often decompensated once the days shortened. That week had been worse than usual because we were short 3 nurses and 1 unit clerk. I had already worked 1 overnight shift, gone home for 6 bad hours of sleep, and come back for a second because staffing could not find anyone else comfortable with intake overflow. By 10 at night, the 3rd floor had the strained brightness every hospital gets when too few people are trying to look calm. The fluorescent lights in intake hummed above the desk. The automatic doors released on a delay and sealed with a soft hydraulic pull. The air smelled like disinfectant wipes, warm plastic, stale coffee, and institutional laundry. From the secure hall came the ordinary sounds I knew too well. Rubber soles on waxed floor. A television turned low behind a patient room door. The distant beep of a pulse oximeter from the medical observation suite. The vent system breathing through ceiling grills. At 11:30, I received a transfer packet from the emergency department for a man named Howard Pike, middle 50s. Brought in after a welfare check, no acute intoxication, mild dehydration. Paranoid content without overt agitation. He was medically cleared for psychiatric admission. I reviewed his transfer paperwork, checked the emergency physician note, and saw an entry under prior admissions that stopped me for a moment. St. Gabriel Behavioral Health, Ward 13, 2 previous stays. I frowned at it because our live units were 9, 11, and 12. There was no 13 on the directory, no 13 on bed placement, no 13 on the floor map posted beside the fire pull station. I asked Jerome Keats, our night clerk, whether Ward 13 had been an old designation. Jerome had worked there long enough to treat every administrative oddity as weather. He tugged a jammed page from the printer tray and said the 3rd floor had been renovated years back. Maybe it used to be the East Hall, maybe geriatric psych, maybe the system still pulled old location codes. Then he shrugged and went back to the printer. That answer was reasonable, so I accepted it. Howard arrived just after midnight in paper scrubs from the main hospital. He was thin, dehydrated, and so calm that he made me more cautious than a louder patient would have. During triage, he watched me with careful attention, as if he were waiting for me to say something specific. I checked his blood pressure, pulse, pupils, tremor, orientation, and affect. I asked the standard questions. Did he know where he was? Did he understand why he had been brought in? Did he have thoughts of harming himself or anyone else? He answered appropriately until I asked whether he had ever been admitted to St. Gabriel before. He said yes, but not to the floors you still admit to. I asked what that meant. He glanced past me toward the secured hall and said, "They moved me off 13 after the second reassignment." I told him there was no Ward 13. He gave me a tired smile that felt too patient for an actively psychotic man. Then he said, "Not on the board." And after a pause, he added, "You should not work doubles when they are still using intake to clean the records." I asked if we had met before. He said maybe not this version. Patients said strange things all the time. That was not mockery, it was the nature of psychiatric work. People in withdrawal, mania, grief, neurological injury, sleep deprivation, psychosis, and severe depression often spoke in ways that were internally consistent to them and impossible to map cleanly onto consensus reality. My job was not to argue. My job was to assess, contain risk, and document accurately. So I redirected, completed the nursing assessment, inventoried his belongings, and placed him in a temporary observation room pending bed assignment. At 1:15 in the morning, while reconciling medications for 2 new admissions from county emergency, I reopened Howard Pike's chart to verify his outpatient pharmacy history. His prior admission field was blank. Not corrected, not updated, blank. I pulled the printed transfer form from the clipboard. It still showed Ward 13 in the prior admission line. On the screen, that line no longer existed. I refreshed the chart, logged out, logged back in, checked the audit trail. No recent changes were recorded. That irritated me more than it frightened me. Hospital software failed in small, humiliating ways every day. Fields vanished, duplicate medical record numbers merged badly. A note entered on one platform did not map correctly onto another. The electronic record could make a competent nurse doubt her own eyesight before lunch. I printed a discrepancy report for morning staff and kept working. At 2:05, a woman named Brianna Cole came in on an emergency hold after telling an urgent care physician that the walls in her apartment had started breathing in time with her. She was exhausted, embarrassed, and apologizing so much that I immediately suspected she was more frightened than unstable. During her intake, she kept looking toward the locked hallway behind me. Finally, she asked whether I was sending her back to the room with no window. I asked whether she had been admitted previously. She looked at the clock, frowned, and said, "Last night, I think." Then she corrected herself, "Maybe last winter." I asked where. "Ward 13, she said, "the one where the vents get loud after 3 in the morning." Her chart showed no prior psychiatric admissions anywhere in our system. No outside behavioral health records, only a prescription history from a primary care clinic in Burbank. But when I printed her wristband and scanned it at the intake station, the system rejected it once before accepting it. For less than a second, a line flashed across the monitor. W13 transfer pending. Then it was gone. I stared at the screen until Jerome asked whether the scanner had frozen again. I told him it had glitched. He said facilities had updated badge access the week before and the network had been acting unstable since then. He said it the way people explained away flickering lights in very old houses. Annoyed, dismissive, determined not to look harder. At 2:40, the charge nurse on Ward 11 called intake and said bed placement showed a full census even though room 4 was empty and cleaned. That kind of mismatch mattered. If the electronic board showed a bed occupied, pharmacy might keep sending medication. Environmental services might never clear the room. Emergency admissions would stack up downstairs. I opened the live census screen and started tracing the discrepancy. The occupied bed belonged to a patient named Marianne Vale, admitted 3 days earlier. Female, age 42, Active psychiatric status. Assigned location Ward 13, Room 6. There was no active Ward 13 in the bed management menu. No Room 6 attached to any live unit. When I opened her summary, entire sections were empty. No insurance. No emergency contact. No discharge barrier note. The medication administration record contained several doses of haloperidol and lorazepam signed by nurse initials I did not recognize. The attending physician field showed a blank placeholder. The legal hold section was empty. I printed the summary and took it to Danielle Mercer, the night charge nurse. Danielle had the steady face of someone who had survived enough hospital nights to recognize danger before it announced itself. She looked at the paper for less than 10 seconds and said the chart was corrupted. She told me to flag it for information systems and stop wandering through dead fields in the middle of the night. I asked her if there had ever been a Ward 13. She held my gaze just a little too long. Then she said the third floor had been reconfigured before I was hired and some legacy locations still surfaced in old records. Her tone ended the conversation. But instead of throwing away the printout, she folded it once and slipped it into her scrub pocket. That stayed with me. By 4 in the morning, the worst of the shift had passed. One patient was asleep with the television still on mute. Another paced the far hall in grip socks. Ice dumped into the machine and staff nutrition with a crackle like breaking glass. I used the quiet to finish charting. When I opened my intake note for Howard Pike, 3 paragraphs were gone. Everything he had said about Ward 13 had been replaced by standard language stating that the patient denied prior admissions and presented no unusual references to hospital locations. The timestamp was unchanged. My signature sat neatly at the bottom. I know my own charting. Every nurse does. You can see yourself in the rhythm of it, where you place description before assessment, how you phrase effect, what you put in quotation marks. The note on the screen wore my name, but not my language. I checked Brianna Cole's intake note. Same thing. Her mention of the room with no window and the loud vents had disappeared. In its place was a bland sentence saying the patient offered inconsistent chronology due to poor sleep. I went back to my handwritten triage pages. The original details were there in pen. When I showed the mismatch to Jerome, he read both versions and asked whether I might have mixed my scratch forms from the previous shift with the current one. It was a fair question. I had been awake too long. The lights had made every hour feel interchangeable. For one dangerous moment, I almost accepted his explanation. Then I saw the patient label on Brianna's scratch page. I had printed it less than 2 hours earlier. At 4:30, I took my break in the staff lounge without touching the coffee. Through the narrow window over the sink, I could see the parking structure lights through a thin layer of coastal haze. Los Angeles looked artificial at that hour, as if too many rooms stayed illuminated so the city would not have to acknowledge how many people were awake and unhappy inside them. I logged into the intranet and pulled archived floor plans for behavioral health. The current map showed wards 9, 11, and 12, plus group rooms and administrative offices where the old East Corridor had once been. But a scanned fire safety diagram from 8 years earlier showed another secured hall branching off the third-floor stairwell. Ward 13, 6 beds, 1 seclusion room, medication room, charting alcove. Stamped across the bottom in red were the words decommissioned after event review. No explanation followed. Hospitals never become fully electronic. They only hide their paper better. St. Gabriel kept archived nursing binders in a basement file cage near materials management. My badge should not have opened it, but at 4:50 the reader flashed green. Inside, the air was colder than the rest of the building and smelled like cardboard, bleach, and old paper. I found psychiatric shift logs from late 2019 and early 2020. Several pages had handwritten annotations in blue ink instead of typed summaries. Patients reassigned. Observation level unchanged. Family not updated pending chart merge. Do not discuss prior rooming history until administrative review complete. There were names, then the same names again weeks later with minor spelling differences. One loose staffing sheet listed badge numbers beside float assignments. I recognized Jerome's, Danielle's. Then halfway down the page I saw mine, my employee number beside Ward 13 intake support. The date on the page was November 17, 2019. 4 years before I had supposedly been hired. I checked it twice. When I tried to copy the page, the basement machine gave me a blank sheet on the first attempt, a page of grid lines on the second, and a service error on the third. When I came back upstairs, Danielle was waiting by intake. She asked where I had been. I told her I was verifying old floor plans because multiple patients had referenced a sealed unit. Then I showed her the staffing sheet with my badge number on a date before my employment. She did not touch it. Very quietly, she said, "Badge numbers get reused." Mine did not. I knew that because Human Resources had explained the numbering system during orientation. Numbers stayed permanent across the health network. Danielle looked at me with something worse than disbelief. It was pity. She asked whether I remembered my first week at St. Gabriel. I said yes. She asked who precepted me. I opened my mouth and found nothing. Not the ordinary blank of forgetting a name. Something much stranger. I could remember the layout of the medication room from my first shift. I could remember compliance modules, linen cart placement, the ache in my feet after learning the intake route. But I could not remember a single face attached to my beginning there. My work history existed in my mind the way a photocopy exists. Accurate enough to pass, thin where it should have had weight. Danielle told me to finish the shift and go home. At 5:20, I checked the board one last time before day shift report. Howard Pike was gone, not discharged in the ordinary way. No transport note, no handoff. His observation room was empty, mattress bare, linen stripped. The camera feed for that hall showed a block of static from 3:52 until 4:06. Brianna Cole's chart was still active, but now it showed 3 prior admissions at St. Gabriel, all on Ward 11, each note bearing a version of my signature on dates I had not worked. Then I heard a call bell, not from any active room. From beyond the fire door at the end of the administrative corridor where there should have been 2 offices and a supply closet. I asked Jerome whether he heard it. He said, "Heard what?" I went through the fire door. The corridor beyond should have ended in 20 feet. Instead, it stretched deep into dimmer light, the air noticeably cooler, the floor wax older, the hum of the building lower and more distant. On one side were patient room doors with narrow wired windows painted over from the inside. On the other sat a dark nurse's alcove with a census monitor glowing green. Ward 13. The call bell display showed room 6. I went to room 6 because training overrides fear for several seconds after fear should already have taken over. The room contained a low bed, a bolted chair, no window, and 1 patient under a hospital blanket. Marianne Vale. She was awake, calm, and impossibly familiar in the way some faces are familiar inside dreams before you know why. She looked at me as if I had arrived late for an appointment. "You took longer this time," she said. I asked whether she knew me. She lifted her wrist. The band facing outward did not show her name. It showed mine. Elise Brennan. Active admission. Ward 13. Transfer pending. I stepped backward into the door. Marianne told me not to leave before the chart updated. She said the room closed if you interrupted the transfer. I asked where Howard Pike had gone. "Reassigned," she said. I asked what that meant. She said it was what the hospital did with inconsistencies. People who remembered the wrong physician, the wrong floor plan, the wrong room, the wrong history. Patients whose records did not reconcile. Staff who noticed the seams. The system could not discharge contradictions, so it redistributed them. A detail moved into another chart. A note rewrote itself. A face shifted to another surname. A nurse forgot who trained her. The building changed just enough between shifts that anyone who complained sounded overtired. Then she told me Ward 13 was where unresolved people waited while the paperwork caught up. I said that was impossible. She nodded in a way that made me think she had heard the objection before. Then she pointed to the chart rack beside the bed. Inside were paper nursing notes in my handwriting across months of dates. Sleep observations, medication rationales, incident reports. Each described patients insisting they had come from Ward 13. Each ended with some version of the same sentence. Nurse unable to verify prior location. Will reassess when rested. At the bottom was an admission assessment with my name in the patient field. Primary complaint, persistent memory discrepancy related to unit architecture. I asked Marianne who she was. She said someone they could not finish moving. Then she asked me whether I remembered driving to work that night. I tried to picture the freeway, the parking structure, the employee elevator, my badge against the reader. I could produce fragments, but no sequence, no arrival, no start. That was the worst moment of the night. Not seeing my name on the band, not the corridor, not the impossible room. It was the clean, physical sensation of a memory failing where a continuous life should have been. I ran. The corridor shortened as I moved through it. By the time I hit the fire door, I was back in the ordinary administrative hall with 2 offices and a supply closet. Intake was bright with day shift noise. Someone laughed near the copier. A resident asked whether there were any overnight holds pending reassessment. Jerome looked up and asked if I was ready to give report. On the board, Howard Pike had been discharged home at 4:12. Brianna Cole had never arrived according to the overnight log. Marianne Vale did not exist in active census. In my charting queue sat 1 incomplete assessment under a hold patient with no listed name. Current location, Ward 13, assigned nurse Elise Brennan. I left 2 days later, at least according to the resignation email in my sent folder. I do not remember writing it. Payroll records showed a final deposit. A month after that, a benefits notice arrived at my apartment addressed to former inpatient Elise Brennan and thanked me for choosing St. Gabriel Continuum Services. I never called them about it. Some institutions survive by making every contradiction look clerical. And sometimes, very late, when sleep thins out and the room goes quiet, I hear a call bell ringing from the far end of a corridor that should not exist, steady and patient, as if my chart is still open and someone is waiting for me to finish the transfer. Story 2. The Last Sleep Study. At 1:27 in the morning, the cardiac tracing on monitor 3 spiked into tachycardia, and the time stamp beside it read 1:34. 7 minutes ahead. I checked the wall clock, then the backup clock above the intercom, then the digital timer on the polysomnography system. All 3 agreed on the present. The screen did not. On the audio channel, I heard a patient gasp and say, "Please do not wake me yet." He had not spoken. His room microphone was still carrying only the low rush of forced air through the vent. Then, exactly 7 minutes later, the tracing repeated itself in real time, and from down the dark hall I heard that same frightened voice say the same sentence in the same cadence, as if the monitor had not predicted the event at all, but remembered it first. In the winter of 2011, I was a senior sleep clinic technician at North Shore Neurological Sleep Research Center outside Duluth, Minnesota. The facility sat on a bluff above Lake Superior, isolated from town by a 2-lane road that turned white and indistinct every time the lake-effect snow came in hard. It was not a hospital in the usual sense. We ran overnight polysomnography, seizure monitoring, parasomnia evaluations, and a small research wing studying sleep architecture in patients referred from neurology. My work had a reputation for being easy because outsiders assumed sleeping patients required less attention than awake ones. In reality, the night shift in a sleep lab demanded a very specific kind of patience. We attached electroencephalography leads to the scalp, electrooculography electrodes near the eyes, respiratory belts to the chest and abdomen, pulse oximetry probes to fingers, electrocardiography leads, snore microphones, tibial sensors for limb movement, and often video monitoring with infrared backup. We calibrated signals, corrected artifact, watched sleep stages unfold in 30-second epochs, and intervened when apneas, seizures, dangerous parasomnias, or cardiac events appeared. It was careful work, quiet work, the kind of work where small errors propagated into entire false narratives if you did not catch them early. I had been doing it for almost 9 years. By then, I could identify stage transitions from the shape of a waveform before the software labeled them. I knew the difference between a loose lead, an eye blink artifact, and a genuine cortical discharge. I trusted equipment, but only the way experienced people trust anything, provisionally. With the understanding that every machine fails in the language it was designed to hide. The night everything changed, a blizzard had already closed most of the county roads by early evening. We were running only 4 studies instead of our usual 8 because 2 patients had canceled. The facility administrator left before dark. The on-call neurologist remained available by pager and landline. That left me, one junior technician named Laurel Vance, and a respiratory therapist borrowed from a neighboring hospital in case the storm forced us to convert a diagnostic study into positive airway pressure titration. By midnight, the building felt cut off from the world. Snow hit the windows in dry bursts. The backup generator cycled once when the lights dipped, then settled. The heating system made a deep mechanical thrum under the floor. On the monitoring wall, 4 rooms glowed in infrared grayscale. The effect was always unsettling to people new to the field. Sleeping strangers under fixed cameras looked less like patients than evidence. Room 1 held a middle-aged woman with violent periodic limb movement disorder. Room 2 held a truck driver with severe obstructive sleep apnea. Room 4 held a young man referred after suspected nocturnal seizures. Room 3 held a patient admitted under the name Owen Mercer for recurrent REM behavior disorder, fragmented sleep, and self-reported dream continuity across multiple nights. His intake paperwork said he was 38. No significant medical history, no psychiatric flags, no prior sleep studies in our system. But from the moment I attached his leads, I had the odd impression that I knew his face. Not from anywhere specific. It was the way his expression settled when he closed his eyes, as if I had watched that exact face under infrared before. He was polite, attentive, and oddly unsurprised by the storm. While I was adjusting his airflow cannula, he asked whether we were likely to lose time again. I assumed he meant power. I said the generator was reliable. He gave a small nod and replied, "That is not what I meant, but all right." I have heard stranger things from exhausted patients. Sleep disorders produce odd speech, and fatigue can flatten even obviously abnormal remarks into something manageable. I finished calibration, confirmed eye movements, jaw tension, leg activity, and lights out, then returned to central monitoring. Owen reached REM far too fast. Normal sleep onset REM happens in certain narcolepsy presentations and under specific rebound conditions, but this was different. He cycled through light sleep, dipped into deeper non-REM, and entered REM with a pattern that looked almost rehearsed. The software flagged a probable staging error. I rescored manually, same result. At 12:58, his eye movements intensified, his heart rate rose, and his EEG showed bursts of unusual activity that did not look frankly epileptiform but did not resemble ordinary dream physiology either. I placed a time marker and made a note for the neurologist. At 1:12, the video monitor showed Owen sitting upright in bed with his eyes still closed. He remained motionless for almost 20 seconds, then lay back down. Laurel asked whether I wanted to call the room. I said not yet. Patients with REM behavior disorder can show partial motor breakthrough. If he became unsafe, we would intervene. At 1:27 came the future tracing. The wall clock said 1:27. Monitor 3 said 1:34. The electrocardiogram jumped. The respiratory belt tightened, and the audio line carried Owen's voice saying, "Please do not wake me yet." Then everything reverted to quiet, present time. Laurel looked at me and asked if the software had frozen. I checked system time. Correct. Server time. Correct. Acquisition station time. Correct. I reopened the epoch. The future stamp remained. At 1:34, the exact event occurred in real time. Same heart rate rise, same respiratory effort, same sentence into the room microphone. Owen sat upright in bed with his eyes closed and said, "Please do not wake me yet." Laurel swore softly. I used the intercom and asked him to lie back and relax. He complied without opening his eyes. The rational explanations were limited but still available. Software artifact. Buffer misalignment between audio and time stamping. Corrupted recording file. Storm-related power fluctuation. I had seen equipment do humiliating things before, but I had never seen a live physiological stream announce an event several minutes before it occurred and then reproduce it exactly. At 1:40, I marked the study as technically irregular and called the neurologist on the landline. No answer. I tried the pager callback number. Nothing. The storm was probably interfering. Meanwhile, Owen continued cycling into REM at impossible intervals, each bout separated by too little wakefulness and too little stable non-REM sleep to make sense. Then it happened again. At 1:53, the monitor displayed a movement arousal time stamped 1:59. Audio carried my own voice saying, "Owen, stay with me." I had not spoken. 6 minutes later, room 3 erupted into activity. Owen twisted against the leads, tangled his cannula, and nearly rolled from the bed. I entered the room with Laurel, steadied him, and heard myself say, "Owen, stay with me." When I came back to central monitoring, the future event had vanished from the active stream and persisted only in the saved clip. By 2:20, the storm had cut outside communication almost completely. Landline calls either failed or returned static. Cellular service dropped to 1 bar and then disappeared. The generator kicked again. Lights dimmed and the central hall took on that isolated institutional feeling I have only encountered a few times since, when a building seems to understand that no one beyond its walls is coming soon. Laurel wanted to terminate the study. Under normal conditions, I would have considered it. But discontinuing a complex overnight acquisition in a storm carried its own risks. Patients still had to be monitored. The road was closing. If the generator held, the safest place for everyone remained inside. At 2:30, I reviewed Owen Mercer's intake packet again. The handwriting on the paper consent form looked older than it should have. The ink faded at the edges as if copied repeatedly. His emergency contact section was blank. His insurance verification line contained only the word internal. That was not one of our standard entries. I searched the archival database for prior visits. None under Owen Mercer. Then, because the face was still bothering me, I widened the search by date of birth and partial physical descriptors. The system returned 3 old studies under different names, with incomplete photographs attached to scanned paper jackets. 1994. Ethan Morrow. 2002. Daniel Keene. 2007. Paul Nellis. Each file had missing fields. Each listed recurrent dream retention or observational instability under the clinical comments. Each patient photograph, grainy and poorly scanned, showed the same face at different ages. I called Laurel over without telling her what I expected. She looked at the images, then at the live infrared of Owen asleep in room 3 and went silent. It is hard to describe the quality of fear that arrives in a medical setting before anything visibly monstrous occurs. It is not cinematic, it is procedural. Your mind starts itemizing things that do not fit. Dates, signatures, calibration notes, missing consent forms, a face recurring under different names across nearly 20 years. You keep waiting for a clerical explanation because the alternative would require rebuilding reality from smaller pieces than you know how to handle. We kept older backups in a locked media cabinet, magnetic tapes labeled by month, because the center had maintained parallel analog archiving long after most facilities abandoned it. I retrieved the tapes tied to the earliest cases and loaded one into the auxiliary playback station. The recording quality was poor, black and white video, warped audio. A room with older equipment and the same narrow wall clock our center had never replaced because it kept better time than newer models. On screen, the patient labeled Ethan Morrow slept under a heavy blanket while a technician off camera ran a standard microphone check. Then, 30 seconds before the technician entered the room microphone captured the entire exchange. A voice asked, "Can you hear me?" Another voice answered yes. Then half a minute later, the technician entered and spoke the same words again in the same order. I checked the tape for splice damage. None. I ran the clip twice more and caught something on the third viewing that made my skin go cold. The off-camera technician's voice sounded like mine. Not similar. Mine. I was not alive in that room in 1994. But the voice giving sleep lab instructions from that tape was unquestionably mine. Laurel heard it too. Laurel heard it. She asked whether we should wake every patient and lock down the unit. I told her to stay with the monitoring room while I checked the research archive office for physician notes. The research wing sat past a short corridor usually kept dark overnight. As I walked there, the building seemed quieter than before, as if snow had packed itself around the walls and muffled the entire world. My shoes squeaked on polished floor. The emergency exit sign at the end of the hall cast a low red wash across framed photographs of former medical directors. The archive office was unlocked. Inside, the shelves held study binders from pilot trials the center no longer advertised. Sensory deprivation, sleep retention, memory continuity and recurrent parasomnia, dream state observation under prolonged environmental isolation. Most of it looked like failed academic work, the sort of thin-funded research institutions bury once it stops producing publication-friendly results. Then I found a binder marked continuity cohort. The language inside was clinical to the point of cruelty. Certain subjects, it said, displayed persistence of observational fragments across repeated sleep entries despite record reassignment. The phenomenon appeared more stable when witnessed by the same technician. Staff with prolonged overnight exposure demonstrated partial incorporation into the loop and improved predictive tolerance. When identity drift exceeded acceptable thresholds, subjects were readmitted under alternate administrative profiles to maintain continuity of observation. The lab was not merely documenting dreams, it was preserving recurring pieces of people who did not fully wake in time. There were handwritten annotations in the margin from a director named Harold Sayer. Keep subject asleep until sequence completes. Waking early increases spread. Observers retain residue. The word residue had been underlined twice. I took the binder back to central monitoring. Laurel was pale and shaking. She pointed to the active screens. All 4 patient monitors now showed event markers ahead of real time. Room 1 had a desaturation warning stamped 2 minutes in the future. Room 2 displayed a snore-related arousal that had not happened yet. Room 4 showed a leg movement burst before the patient's body twitched. But Room 3 was worst. Owen's live feed now contained overlapping timestamps, as if multiple versions of the same night were trying to occupy one display. One line read 2:46, another read 3:03. The wall clock said 2:41. Then room audio carried a sentence I had not yet heard but somehow recognized before it finished. You always check the old tapes before you understand. The voice was Owen's. I looked at the screen. He was still lying still in bed. A few seconds later, he opened his eyes on the monitor and turned directly toward the infrared camera. Laurel whispered that she was leaving. I told her not to step outside in blizzard conditions with the roads closed. She said she meant the building. She got halfway to the door, stopped, and turned back with the confused expression of someone who has forgotten why they stood up. Then she returned to her chair and stared at monitor 2 as if nothing had happened. That was when I understood the notes about observational drift. The longer you stayed inside the pattern, the less certain your own sequence became. At 2:46, just as the future timestamp had predicted, room 1 desaturated. I handled it automatically, adjusted the sensor, verified airflow, and returned. At 2:51, room 4 showed a brief seizure pattern exactly where the screen had marked it. At 2:59, my intercom light flashed before the patient in room 2 moved and played me his next sentence through static. The equipment was no longer predicting events. It was displaying a version of the night that had already happened somewhere adjacent to ours. I went to room 3 alone. Owen was awake when I entered, sitting upright with the leads still attached. He looked tired rather than afraid. You found the cohort binder, he said. I asked who he really was. He smiled with painful patience. That expression was what had felt familiar all night, not his face. The way he looked at me as if I were late catching up to something he had already learned too many times. He said the names changed when the records did. The lab needed new admissions, new insurance profiles, new signatures because a patient could not remain in a study for 20 years without raising questions. So they kept re-entering him. Different surname, different county, slightly different age, same room, same technician eventually. I told him I had never seen him before. He said, not in a way you kept. Then he asked me whether I remembered my first week at North Shore. I thought of the lead cart, the supply closet, the smell of electrode paste and skin prep. I remembered the rhythm of calibration so clearly that I could have performed them in the dark. But I could not remember a single first patient. He watched that realization land. Then he said the lab needed witnesses because a fragment left unwitnessed diffused into dreams and weather and electrical noise. Someone had learned that if they recorded the same consciousness repeatedly, the pieces held together better. Not the whole person, never that. Just enough to recur. Why me? I asked. Because you were good at staying awake, he said, and because you started hearing events before they happened. He pointed to the wall clock above the sink. Its second hand was moving backward, not fast, calmly, one measured tick at a time. I do not remember deciding to remove my own badge. I only remember standing there with it in my hand while the monitor behind me began playing my voice from another year. I could hear myself telling a patient to open and close their eyes for calibration. Then I heard Owen say from both the room and the speaker at once, "If you wake me early, you keep more of it." I backed out and returned to central monitoring. Laurel was gone, or perhaps she had never been scheduled. Her chair sat tucked in, headset coiled neatly, no coffee cup, no worksheet, no sign of another technician ever existing that night. The patient board listed only one active study. Room 3. Patient name field blank. Observer assigned Nolan Avery. That was me. The storm broke sometime after dawn. Roads reopened by late morning. Officially, the night report documented unstable recording software, one incomplete study, and weather-related communication failure. The research binder disappeared when I went back for it. The old tapes were reboxed and relabeled. Owen Mercer had no discharge summary because, according to intake, he had canceled before arrival due to the blizzard. I worked at North Shore another 6 months. At least, that is what payroll records suggest. I have only scattered memories of that period. Some mornings I woke convinced I had already lived the entire shift ahead of me. Some nights, before falling asleep, I would hear the intercom click and my own voice would come through softly from nowhere, asking some patient to move their eyes left and right for calibration. I left the field after that winter, but clocks still bother me, especially digital ones. Sometimes in the minutes before dawn, a bedside display will change ahead of itself, and I will feel the old professional reflex to mark the event, verify artifact, and stay with the patient until the sequence completes. That is what unsettles me most. Not that the lab preserved fragments of sleeping people, but that part of me still responds like an observer. As if some buildings do not merely study the vulnerable, they teach the staff how to hold them in place. Story 3. The organ recovery floor. The first donor consent form arrived at 11:40 at night, printed on trauma center letterhead and signed by a man who was still alive upstairs. I knew he was still alive because I had just spoken with his wife in surgical intensive care less than 20 minutes earlier. He was intubated, heavily sedated, unstable after a ruptured aortic injury from a highway rollover, and nowhere near formal brain death evaluation. Yet the paperwork on my desk listed him as an authorized donor with procurement clearance pending and family approach completed. His signature was at the bottom in a hand so steady it looked practiced. Above his name, someone had stamped the destination for further review. Recovery floor. There was no recovery floor on any map at Memorial St. Jude Trauma and Transplant Center in Houston. By the summer of 2026, I had spent 11 years in organ donation coordination. I was not a surgeon, not a procurement nurse, and not the person families usually imagined when they heard the word transplant. My work began in the procedural gap between devastation and logistics. When a ventilated patient met referral triggers, bedside staff called us. We reviewed neurological exams, injury severity, hemodynamic stability, infectious disease risk, prior medical history, and family contact information. If brain death testing or withdrawal planning moved toward donation eligibility, we coordinated timelines, labs, serology, tissue typing, operating room access, and communication with the National Allocation System. It was delicate work because every hour mattered and every sentence mattered more. Families remembered the exact wording you used at the worst moment of their lives. Intensive care teams resented delays but feared mistakes. Surgeons thought in ischemic time. Administrators thought in throughput. Coordinators had to think in all those languages at once without sounding mechanical. Memorial St. Jude was built for scale. It was a major trauma hospital, transplant center, and regional referral hub with rooftop helipad access, multiple surgical towers, and an administrative structure so layered that important decisions could become anonymous within minutes. In late August, with a hurricane building in the Gulf and evacuation prep starting for lower acuity units, the place took on that tense, over-organized feeling large hospitals get before a weather emergency. Extra cots appeared in conference rooms. Pharmacy double-checked backup refrigeration. Elevators prioritized critical transport. Supply chain moved bottled water and sterile packs into hall storage. Everyone spoke too calmly. I was on overnight emergency coverage because 2 coordinators had been diverted to a multi-vehicle trauma surge on the east side, and our regional call volume was rising. By 10 that night, I had already handled 3 referral reviews, 1 family meeting, and a near miss with incompatible blood bank documentation that turned out to be a duplicate wristband error. The donor consent packet that arrived at 11:40 belonged to Evan Rourke, age 36, admitted after rollover trauma from Interstate 10. I had seen him in surgical intensive care at 11:22. He was alive, though barely stable. No formal neurological determination had begun. No family authorization discussion had occurred because his wife had not yet been briefed by the attending trauma surgeon. Yet the paper on my desk showed a completed authorization, destination recovery floor, and an internal routing code I had never seen. I assumed the obvious first. Wrong chart, training file, cruel joke. I called the unit. The bedside nurse, Kendra Moss, confirmed Evan remained ventilated, sedated, and on escalating pressor support. I asked whether anyone had approached family about donation. She said absolutely not. Then she hesitated and asked me something that sounded foolish until the rest of the night proved otherwise. "Has he been downstairs already?" she said. I asked what she meant. She lowered her voice. "Nothing. Forget it." She hung up before I could press her. I scanned the consent form into the electronic record and opened Evan's chart. For 2 seconds, the document indexed normally. Then the system refreshed and moved it under completed transplant donor documentation, as if he were already deceased. I checked the status banner. Still alive, still admitted surgical intensive care, still full code. The discrepancy should have triggered alarms. Instead, the chart behaved as though both states could coexist without conflict. Just after midnight, the first power flicker hit. Lights dimmed, monitors chirped, then backup current stabilized before anything shut down fully. Through the windows of the coordination office, rain sheeted across the parking decks in hard, diagonal lines. Somewhere outside, wind pushed loose signage against concrete with a repeating metallic bang. My office sat near case management on the 4th floor, not far from the transplant finance team and the small suite where we kept hard copy donor binders for legal redundancy. Most people assumed organ donation was an entirely digital process by now. It was not. Too many signatures, serology chains, transport authorizations, death pronouncements, and external agreements still depended on paper. In bad weather, paper became the real system. At 12:15, I received a call from the transplant step-down floor. A liver recipient 3 days post-operative, stable until then, had become agitated and was asking for a woman named Maribel Cates. Nobody on the unit knew the name. The nurse called me because the patient insisted Maribel was waiting downstairs for the rest of her. That kind of confusion was not unheard of after major surgery. Sedation, delirium, sleep disruption, pain medication, and metabolic shifts could produce bizarre statements. I asked whether the patient had a fever, worsening ammonia, hypoxia, or signs of withdrawal. The nurse said no to all of it. Then she added that the patient kept describing a convenience store robbery in Corpus Christi from 1998. The liver recipient was 21 years old and had never been to Corpus Christi. I made a note to follow up after finishing the active donor reviews. At 12:40, another form printed automatically to my office queue. Different patient, different floor. This one belonged to a woman in neurointensive care after a devastating intracranial hemorrhage. She too was still alive. She too had a completed authorization packet. And she too had the same routing stamp. Recovery floor. I took both forms to transplant operations. The administrative supervisor on duty, Michael Torin, barely glanced at them before saying the system occasionally populated premature templates during severe network instability. He told me to shred the duplicates and wait for information services to clear the backlog in the morning. I asked him what recovery floor meant. He paused long enough for me to notice. Then he said it was probably an old storage designation. That answer was too smooth. Large hospitals survive on smooth answers. If you work inside one long enough, you learn to distinguish ordinary reassurance from institutional reflex. Michael was not explaining anything. He was moving me along. At 1:10 in the morning, surgical intensive care called again. Evan Rourke's wife wanted to know why someone from donation services had already spoken with her husband. I went cold. I asked Kendra who had spoken with her. She said Mrs. Rourke insisted that during a brief sedation interruption, Evan opened his eyes and told her he had already signed what they needed downstairs. He allegedly said the woman with the blue folder explained where the memory part goes. I always carried blue folders on active cases. I had not said any such thing, but when I tried to dismiss it as confused perception, Kendra told me something worse. Mrs. Rourke described the woman accurately. Brown hair pinned up, navy rain shell over scrubs, silver trauma pager clip. That was me. That was exactly what I had been wearing. I went upstairs immediately. Evan was still intubated, deeply sedated, hemodynamically unstable, skin gray with the drawn look trauma patients get when the body is spending everything it has on maintaining the simplest functions. He could not have held a coherent conversation. His wife, Tessa, sat rigid beside the bed. She looked less grief-stricken than offended, the way people do when they realize a system has moved faster than their humanity. She asked why I had returned when we had already talked downstairs. I told her we had never spoken privately before that moment. She stared at me and said, "You told him memories are easier to match than organs if the paperwork is clean." I felt the floor shift under me in a way that had nothing to do with weather. I said I would never say something like that. She studied my face as if she believed me and did not know whether that was better. Evan's chart, when I checked it at the bedside workstation, contained a donor suitability note signed with my credentials at 12:02 in the morning. The note used my documentation template and included phrasing I genuinely might have written under other circumstances, only the content was impossible. Candidate demonstrates favorable continuity indicators. Family likely cooperative after exposure. I did not chart that note. I reported the unauthorized entry to clinical information security and called my supervisor, who was sheltering at home due to the storm. Voicemail. I called again. No answer. At 1:50, the elevators in Tower C began misrouting staff. A respiratory therapist headed for neonatal intensive care arrived instead in an unused perioperative corridor. An environmental services worker trying to reach the loading dock found herself on a half-lit floor with no unit signage and no patients in the rooms. Facilities blamed badge read failures during voltage fluctuations. Security told everyone to use the main bank until systems stabilized, but the main bank was where the problem lived. At 2:10, after another call from step-down about the liver recipient, I took elevator C3 from the 4th floor to transplant step-down on 7. The display rose normally to 5, paused, then showed no number at all. The car kept moving. When the doors opened, I looked out onto a surgical corridor I had never seen. The air was colder. The lighting was lower and more amber than the rest of the hospital. There was no patient traffic, no overhead paging, no squeak of transport wheels, only a distant filtered hum from large ventilation units. On the wall across from the elevator hung a brushed steel sign. Organ recovery floor. No unit number, no directional arrows. Just that. I hit door close immediately. The doors began to shut, then reopened halfway as if someone outside had pressed the hall button. No one was there. I hit close again until the car took the command and returned upward. When I stepped out on 7, my scrub top was damp with sweat. Hospitals are full of legacy spaces. Closed ICUs, mothballed wards, shell floors, renovation areas. If I had seen that corridor any other night, I might have written it off as a temporarily inactive surgical wing. But inactive wings do not appear on no map, intercept active elevators, and carry a name identical to unauthorized donor paperwork. I pulled the emergency evacuation plans posted by the stairwell. No recovery floor. No unnumbered surgical level between 5 and 7. No restricted transplant annex. Back in my office, I opened the donor archive binders. Cases from the past 10 years were clean, ordinary, and miserable in the familiar way of donation work. Then I widened the search into older storage. Pre-electronic files, microfilmed case abstracts, hand-corrected transplant ledgers from the late 1980s through the early 2000s. Patterns emerged only after enough pages had passed under my hands to make denial harder than suspicion. Recipients later declared legally deceased despite continued outpatient follow-up. Duplicate blood types across unrelated donor streams with identical antibody anomaly notes. Post-transplant psychiatric consultations documenting foreign autobiographical persistence. Billing corrections moving identity fields between charts rather than correcting procedure codes, and always in the corner of certain files a routing stamp. Recovery. I found a retired coordinator's memo from the late 1990s addressed to transplant administration. The memo complained that recipients were reporting donor dreams, donor cravings, donor names, donor fears of specific rooms, donor fragments that did not fade with immunosuppression or counseling. The writer urged leadership to stop treating memory carryover as anecdotal because case clustering suggested continuity transfer beyond standard psychosocial assimilation. The response attached to the memo was short. Observe. Do not document in patient-facing summaries. There are moments in bureaucratic horror where terror comes not from discovering one monstrous thing, but from realizing how many polite people had already adapted to it. How many committees had softened language around the impossible. How many administrators had found terms like continuity, retention, and reassignment easier to manage than words like personhood. At 2:45, transplant step-down called again. The liver recipient had calmed but now insisted he used to smoke clove cigarettes behind a refinery on the east side. He also knew my name, though I had never met him. When I asked how, he said, "You were there when they moved the rest." I went to see him. He was a college student named Aaron Feltz, recovering well aside from the agitation. He looked embarrassed once the fear passed, the way lucid patients do after saying something they cannot justify. I asked him what he remembered. He said pieces, a woman counting lottery tickets, a flooded apartment, the smell of gasoline in summer rain, a badge on dark blue scrubs, an elevator ride down where nobody talked. He said he knew the liver inside him had come from a donor and that he had expected occasional strange dreams. But this felt different, not dreams. Residency, as if part of someone else had been moved into his body with enough paperwork to make it legal. I asked whether anyone had suggested that language to him. He shook his head and asked the question I had started avoiding myself. "Is that what you people actually transplant here?" By 3 a.m, hurricane alerts were rolling across every staff device. The city had not yet issued full mandatory evacuation for the Central District, but bridge restrictions were beginning and low-lying routes were closing. Memorial St. Jude entered internal lockdown to keep transport flow controlled. Elective surgery was canceled. All non-essential movement stopped. Lockdown made certain kinds of truth easier to hide. Nobody could simply leave, call outside support, or wander floors without challenge. I went to clinical records in the basement with a flashlight because one lighting zone had lost full power. The records clerk on duty, an older woman named Becca Lyle, had worked there since before the health system merger. She saw the folders in my hands and looked tired rather than surprised. "You found recovery," she said. I asked her what it was. She gave the kind of answer people only give after years of saying less than they know. She said the transplant program began noticing mismatches decades ago. Recipients waking with donor memories, donor families claiming their dead relatives were still calling from unknown numbers, patients who survived surgery but became legally inconsistent afterward. The official position was always incidental psychological carryover. Then a few surgeons and administrators began to suspect that viable tissue was not the only thing preserved by rapid procurement and immediate implantation. Something of the donor remained organized long enough to attach. At first it was considered a complication. Later she said someone decided it might be useful. I asked useful how. She said because organs are scarce, but people in power have never stopped wanting continuity. Becca led me to an older ledger room where transplant cases were tracked before digitization. There, in brittle binders, the program became explicit. Candidates selected not only for blood type and body size, but for continuity receptivity. Internal reviews discussing identity retention as an adverse event in public documents and an opportunity in restricted ones. A sealed committee recommendation from 2009 proposed establishing a dedicated recovery unit where unstable transfer cases could be observed until their records aligned with whichever life the institution needed to preserve. I thought of the unauthorized note in Evan Rourke's chart. Favorable continuity indicators. I asked who had approved any of this. Becca gave a small, hopeless laugh. Hospitals do not need one villain. They need decades, hierarchy, and enough people who only see one step of the staircase. Then she looked at me in a way I had already learned to fear. "Did nobody ever tell you why your personnel file is restricted, Lena?" That was the first time that night anyone had said my first name in a way that sounded like bad news. I asked what she meant. She pulled a microfilm printout and laid it on the table. 12 years earlier, before I became a coordinator, before I finished graduate training, before I entered this field at all, I had been a patient at Memorial St. Jude after a freeway collision outside Katy. Critical abdominal trauma, massive blood loss, emergency transplant salvage under experimental waiver language during a declared shortage event. I stared at the page until the letters stopped behaving like language. I had been told after that crash that I had surgery, complications, and a long recovery clouded by sedation. I remembered the hospital only in fragments. My mother had died the year before, and my father avoided medical details the way some people avoid funerals, by shrinking from every word that makes loss more specific. I had never requested the full record. There had not seemed to be a reason. Becca turned another page. Post-recovery note. Patient exhibits transient autobiographical overlap with donor subject. Memory consolidation incomplete. Recommend administrative firewall and future internal placement if stable. Internal placement. I asked who the donor was. She hesitated and said the donor record had multiple amendments. Maribel Cates appeared on one version. Different names appeared on later copies. Maribel. The name the liver recipient had been repeating. The room seemed to tilt without moving. I remembered suddenly and without warning the smell of rain on asphalt, a voice singing along to a radio, clove cigarette smoke near a convenience store awning, a hand with chipped silver nail polish turning a key in a lock that was not mine. Not imagined, not dreamed, embedded. I gripped the table until the flash passed. Becca said that some recipients stabilized and lived ordinary lives. Some did not. Those who adapted well were often drawn back into the institution. nursing, case management, transplant logistics, places where they could help manage future transfers without understanding why the work felt familiar. I asked whether my career had been chosen for me. She said she did not know. But she knew my badge opened areas it should not. Then the basement lights dipped, recovered on emergency power, and every elevator in the building chimed at once. My pager displayed a transport alert from a floor not listed in the system. Organ recovery requesting coordinator presence. I should have gone to security. I should have called state authorities, federal oversight, anyone outside the institution. But storms, hospitals, and fear compress your world. The building becomes the whole problem and the whole possible answer. I went because I needed to know whether I had been working for years inside a machine designed to preserve pieces of the dead by hiding them inside the living. Elevator C3 took my badge without question. No floor number appeared when I descended. The doors opened onto the same amber corridor I had seen earlier, but now it was active. Staff moved quietly between rooms in pale surgical gowns without visible ID badges. Transport beds stood along the wall. Computers glowed at recessed stations. No one looked surprised to see me. That was the most frightening part. I had not discovered a secret floor. I had arrived where the system expected me to report. A woman in old-style scrub whites approached and handed me a clipboard. "Case review pending," she said. "Multiple unstable continuities. Storm may force batch decisions." I looked at the papers on the board. Consent forms, psych consult summaries, blood type sheets, notation columns for donor organ status, recipient status, and continuity persistence. Several names were familiar from current hospital census. Some were alive upstairs, some were post-operative. Some, according to official records, had died years ago. One file carried my own name. Not as staff. As legacy recipient, cohort retained, suitable for renewed partition if critical demand escalates. I could hear my pulse in my ears. The page beneath it contained handwritten notes in a hand I recognized from my own older journals. I had been there before, not once, multiple times. The comments discussed recipients who were retaining too much of the donor self or too little, and whether additional sedation improved alignment. One line stopped me cold. Identity is most stable when the institution remembers for them. I had written that, or a version of me had. I walked the corridor in a state that no longer qualified as disbelief. In one room, a heart transplant recipient stared at the ceiling and mouthed someone else's name over and over. In another, a woman recovering from liver surgery recited an address in Galveston that had been condemned after a flood. In a third, an intubated trauma patient still officially alive on another floor lay connected to monitors while a duplicate chart rested at the bedside awaiting transfer status. The floor was not preserving organs. Organs were only the legal vehicle. It was preserving administratively useful continuity, fragments of personhood redistributed through surgery, sedation, record systems, and the authority of institutions nobody questioned because the surface function was sacred enough. Save lives. Do not ask what else gets moved. At the end of the corridor sat a glass-walled conference room. Inside were shelves of archived binders and a large evacuation map that omitted the floor entirely. A storm command screen flickered overhead. On a central table lay donor packets awaiting review. One belonged to Evan Rourke. Attached to it was a note in my own voice, transcribed by dictation software at 11:58. Spousal resistance likely temporary. Candidate may accept if continuity framed as mercy. I had no memory of dictating it. That was when I understood the deeper mechanism. The floor did not simply preserve donor identity inside recipients. It used people like me, prior recipients with softened boundaries, as administrative tissue. We could move between roles. Staff and patient, witness and participant, coordinator and continuity carrier. Under fatigue, stress, storms, outages, overnight coverage, the separation thinned. The system borrowed our authority because we were already partly rewritten. A man I recognized from transplant administration entered the room behind me. Dr. Victor Harlan, Chief of Surgical Services, still in rolled sleeves and a rain-darkened tie. He looked exhausted but not surprised. He said I was not supposed to find the old ledgers yet. I asked how long he had known. Long enough, he said, to understand that public ethics and practical survival are not always the same. He began speaking in the calm, explanatory tone administrators use when they believe process itself will make horror acceptable. He said every transplant center had anecdotal carryover, but St. Jude had found ways to reduce chaos, to document compatibility not only in tissue but in narrative tolerance, to prevent recipients from fragmenting, to preserve useful identity traces when donor death would otherwise scatter them into nothing. I asked whether living patients upstairs had been pre-processed for continuity before death. He did not answer directly. Instead, he said storms created triage conditions. Triage required difficult decisions. Memory, personality, and continuity were already unstable biological artifacts. The hospital merely prevented waste. Waste. There are words that remove a soul from a body faster than scalpels ever could. I told him Evan Rourke was alive. Victor said alive was often temporary. Records had to move ahead of physiology if the institution wanted any control over what followed. Then he looked at my file on the table and said I, more than most, should understand the value of retention. Because I had survived. Because part of someone else had survived in me. Because my entire career may have been built atop a bureaucratically managed haunting. He asked me to help with the batch reviews before the storm worsened. Instead, I pulled the hard copy packets from the table, grabbed the portable scanner drive from the corner station and backed toward the corridor. He told security to stop me, but nobody moved fast enough. Perhaps they were used to compliance. Perhaps some of them were not entirely sure which role I occupied that night. I ran to the elevator with enough paper evidence to matter if anyone outside the hospital ever read it. The car took me upward, stalled between floors, then dropped several feet before emergency brakes caught. Lights went out completely for 2 seconds. In that darkness, I heard voices inside the car with me. Not strangers, layers. A woman laughing in cigarette smoke, a child counting backwards in Spanish, a man praying he would not be taken off the ventilator, my own voice saying we only move what the chart can hold. When the lights returned, I was alone. The elevator opened on 4. Alarm tones echoed through the main building. Wind pressed rain against the windows so hard it sounded like handfuls of gravel. Staff rushed toward command stations. Nobody paid attention to the folder box in my arms. Hospitals in crisis can hide almost anything inside ordinary chaos. I made it to records where Becca was waiting with a waterproof evidence pouch usually reserved for legal specimen chains. We sealed the drive and copied what we could from the paper packets. Then Emergency Command announced full internal shelter protocol. All movement stopped. Security sealed stairwells below the surgical levels. By dawn, official messaging framed the night as a weather emergency with intermittent documentation anomalies due to network instability. Several patients had been transferred. Several charts had merged incorrectly. One restricted surgical level was referenced in error by legacy elevator logic. Information services would audit the discrepancies after the storm. No one mentioned recovery. No one mentioned the donor form signed by living men. No one mentioned that 3 transplant recipients spent the next day calling nurses by names that did not belong to anyone on staff. I did not report for my next shift. I took the copied materials to a federal investigator 6 days later after the roads cleared and the city stopped operating in emergency mode. An inquiry opened, then narrowed, then dissolved into procedural ambiguity so dense it felt designed. Too many files were missing. Too many signatures were valid. Too many deceased patients had apparently consented to too many things. No one could quite prove it happened. Memorial St. Jude denied the existence of any unlisted surgical floor. Facilities plans submitted to regulators showed no such level. Elevator logs from that night were incomplete due to power disruption. My own personnel file was partially sealed for reasons of prior patient privacy. Becca retired abruptly and stopped answering calls. Dr. Harlan took a leave of absence, then resurfaced at another institution under a consulting title. Sometimes I think the scandal failed because the story was too large for ordinary ethics language. People understand stolen organs. They understand fraud. They understand negligence. They do not understand a hospital deciding that identity itself is a recoverable resource. I still have the copied page that mentions my old transplant. Some nights I take it out and stare at Maribel Cates's amended name until I feel that second life stirring at the edge of memory. I still smell clove smoke in summer rain. I still know corners of Houston I have never lived in. And when elevators hesitate between floors, I feel an old professional reflex rise in me. A certainty that there is another level beneath the visible one where paperwork reaches the body before death does. That is what I carry now. Not proof exactly, not even a complete self. Just the knowledge that some institutions do not save people one at a time. They file them, divide them, and redistribute whatever remains. And when storms come in off the Gulf and the hospital lights dip for a second too long, I still expect the pager to vibrate with a new consult from a floor that does not exist, asking me to come downstairs and help decide what part of someone is worth preserving.